thank you to Drs. Pan and Dr. Malone for kind of arranging this a little bit last minute, but I think it turned out really well, and we're happy to have our first annual, perhaps last annual, but at least first annual Solid Transplant Organ Day. Before we get started, just a quick note and maybe a moment of remembrance for everyone who has donated an organ, because there's such optimism and excitement anytime an organ, of course, becomes available, but it's always tempered by the knowledge that that's the end of life for somebody else and for somebody else's families. So while we remember that, we'll of course learn a lot about the science and clinical side of organ donation. And with that, I will hand it over to Dr. Malone.
So thank you very much for the introduction, and I'd like to thank the Department of Medicine for the opportunity to present to you this morning in this Solid Organ Transplant Day. So myself and Dr. Pan, as mentioned, are going to split this talk into two halves, and I'm going to start giving you an overview of adult kidney transplantation, and hopefully the two lectures or two halves of this lecture aren't a repeat of themselves, swapping kidney for liver. So a little bit of a different angle on the kidney side of things compared to the liver half of the talk. So by way of outline, I wanted to first kind of highlight the impact that kidney disease is having in the United States and across the world, and a little bit about the numbers and epidemiology of kidney disease. And then as people get onto the kidney transplant wait list, some people are on that wait list for a number of years. And so there's a challenges managing patients on the kidney transplant wait list. We'll talk a little bit about transplant outcomes, that is kidney transplant outcomes nationally, and how we compare here at WashU and Barnes Jewish Hospital. And then for the second half of the talk, I want to focus on some special transplant situations, things that we offer at Barnes Jewish Hospital and other centers across the country do also, in an effort to expand opportunities and get more patients to transplant. And then at the end, a couple of slides on the future of transplantation and a particular area that's exciting a lot of us in this field. So in terms of timeline, related to kidney transplantation, the first kidney transplant was done in 1954. This was a living kidney transplant between two identical twins, the Herrick twins, and this was done at the Brigham Hospital in Boston by Hume and Murray. Nearly a decade later, the first deceased donor kidney transplant was done by the same team in Boston. In '66, the first successful kidney and pancreas simultaneous transplant was done in the University of Minnesota. And then some regulations started to come online as transplantation was starting to pick up. The first uniform donor card became a legal document. And then a seminal year for us in the kidney space was 1972, when Medicare and the federal government decided to cover all the costs related to end-stage kidney disease, that is, pay for dialysis and its related treatments, and transplantation and its related treatments in the first 3 years. And we've recently been pushing to extend that beyond 3 years for patients with transplants. In '79, cyclosporin was introduced and revolutionized solid organ transplantation and was passed by the FDA a few years later. And then another event in 1984, so transplantation was gaining a lot of momentum across the country, and certain regions started to evolve organizations in an effort to coordinate the distribution of organs for transplantation. And so the federal government passed this Transplantation Act in '84 and established the OPTN, which is a subsection of HHS, to contract out to a company to organize distribution of solid organs across the whole country. And that organization is UNOS and has held this contract since 1984. They are under pressure at the moment. Again, that same year, there was the first successful combined kidney liver. '84 was a big year. Tacrolimus came online as well and was approved a couple of years later. And then more recently, there's been a lot of changes to the allocation system in the United States. This is not moving forward. In 2014, there was a change to the kidney allocation system. And then in 2021, there was a change to the allocation system for all solid organs across the country. And we're starting to see the effects of this slowly and how it impacts our center and our region. So moving on to some of the epidemiology of end-stage kidney disease, as you can see on the left-hand side, actually the per population incidence of end-stage kidney disease is slightly decreasing, but the prevalence continues to rise and rise quite steeply. So there's more and more people with end-stage kidney disease in the country. A lot of these slides will have a little blip at the end of this graph, because these are the most up-to-date data, and this moves into 2020 data, and perhaps COVID has made an impact on some of these data. We like to think that we're doing pretty well treating our end-stage kidney disease population as a whole, and here you can see that there's a slight increase in all-cause mortality amongst all of those in the country with end-stage kidney disease. And maybe you can ignore the blip at the end. What about patients on the kidney transplant list? So as I alluded to, sometimes these patients are on the kidney transplant waiting list for years, and actually in some parts of the country, you can be on the kidney transplant waiting list for over 10 years. Luckily in our region, it's only a handful of years. That wait list has been growing over the last decade, as you can see in this graph, and there's over 100,000 patients in any one year that are on the kidney transplant wait list. What causes kidney failure or end-stage kidney disease? And by far the biggest cause in the United States is diabetes and diabetic nephropathy. And that proportion of the etiology of patients on the wait list is increasing despite all of the other major indications slightly trending down. And that pertains to an increase not only in our volumes across the country and in this center, but also the complexity of the patient that we're managing. Patients, as you can imagine, who have bad diabetes and end-stage kidney disease because of it, usually have a lot of other comorbidities, cardiovascular and otherwise, that make it challenging to manage these patients on the wait list and post-transplant. While they're on the wait list, similar to the end-stage kidney disease population in general in the country, those on the wait list, their mortality is improving across the country if you ignore the blip at the end. Here's a picture of the United States broken up into random geographical areas, which are have been designated by UNOS. And ours is pointed out in the middle here by the large arrow, and just tells you that we actually, in general, as a region, do pretty well at managing our patients on the transplant wait list when compared to the rest of the country. There is about 6, I think, kidney transplant centers in our region. How do we do in Barnes Jewish Hospital and WashU when compared to the rest of the country? So we actually been traditionally getting patients transplanted quicker than the national average. But perhaps this might change, as in the last year I mentioned. There's been a radical change of the organ distribution policy to make it more equitable. That's the idea, at least. And so this difference between different parts of the country in terms of getting to transplant might even out. In the middle infographic here, you can see that perhaps we do slightly worse in terms of mortality rates at maintaining patients on our wait list. But we like to think that in Barnes Jewish Hospital, we're a high volume center, and so perhaps take on a little bit more risk and try to give more people opportunities that may not have gotten an opportunity to get on the wait list at a smaller center. So to give you an idea of the supply and demand issue, which is a big issue in kidney transplantation, definitely, and actually a lot of talk has been done about this at the higher levels of policy and at the federal government. And actually the last administration went a long way to try and push efforts to change policy to try and narrow the gap between the rising supply or number of patients on the kidney transplant wait list and the relatively stagnant numbers of donors that we have. But at any one time, there's at least 90,000 patients on the wait list for a kidney, and these are numbers from 2020. You can see that there's over 100 patients going onto the wait list every day, and about 13 or so coming off the wait list due to death or severe illness. And about 8,000 or 9,000 brain dead donors are used per year in 2020 at least, and 30,000 cardiac death donors. And on average, when a donor comes forward, there's about 1.5 kidneys used per one donor. And then in 2020, in the country did over 5,000 living donors. So there has been a slight increase in the number of deceased donor kidneys we've been having over the last decade, but living kidney donation is kind of stagnant. But there's a huge gap, as you can see. between who needs and the supply. Looking at some more long-term data here. So when patients do get a transplant, how do their transplants do? So this is relatively recent data. On the left-hand side, how does a kidney transplant do if your donor was from the deceased donor list? And on the right-hand side, if you get a live kidney donor. And these latest data, we're looking at patients who were transplanted in the era of 2014 to 2017. And a deceased kidney will last about 11 to 12 years on average. And a living kidney will last 19 to 20 years. So pretty good outcomes, and they've improved somewhat in recent decades, or the last decade or two. A little bit of a plug again about our program here at Barnes Jewish and WashU. Here I've highlighted publicly available data maintained by the federal government. This is the top 10 kidney transplant programs in the country by volume. And you can see we're number 9 here. These numbers are the number of deceased donor transplants and living donor transplants added. But we're a high volume center, but we are also a very well-performing center, and we're very proud of this. There's only 2 centers in the top 10 by volume in the United States who have excellent kidney transplant outcomes, and the highest marks are those bars on the right-hand column, 1-year kidney allograft survival. And we also do better on mortality post-transplant compared to the average. So we do pretty well, we like to think. So moving on to the second part of this, the talk, that I'd like to kind of highlight some of the things that we can do to help perhaps groups of patients who might not otherwise have gotten a transplant in the past, or efforts to increase the number of kidneys available or that we can use for transplant. So the first population is HIV-infected patients. Previously, or years ago, it was thought, you know, that it was probably not a good idea to do a kidney transplant in a HIV-infected patient, given the relationship between HIV and the immune system. And with a transplant, we would be giving them heavy immunosuppression in the short and long term, and that immunosuppression is primarily directed against T cells. But actually, it became apparent, and more studies came online to show that actually patients who are infected with HIV do a lot better in terms of 5-year mortality rates. Here numbers are 80% better at 5 years if you transplant that patient compared to that patient remaining on dialysis on the wait list. And that's true even if they're co-infected with hepatitis C. Their 5-year mortality rate is 90% improved. There is some lead time required here. They need to get over the initial transplant period, but you need to make sure that your patient is well selected. So a slight overview of how we approach things here at Barnes Jewish in our HIV positive transplant program. We put regular non-infected kidneys into these patients. The HIV positive recipients need to be well managed. They need to be stable. Their HIV status needs to be suppressed. They need to be on a stable heart regime, and preferably that heart regime needs to be a regime that has minimal interactions with the drugs that we might use, and a common favorite is Biktarvy. They need to be stable in terms of having no ongoing active infection or malignancy or other complications of HIV. And then, of course, if they've got a hepatitis B or C co-infection, we need to ensure that their liver is in pretty good shape before going forward and offering this type of transplant. And sort of as an aside, and kind of on the research end of things still at the moment, there was a lot of data coming originally out of South Africa, I think, where it might actually be possible to use kidneys from HIV positive donors. And this has been looked at over the last 10 or so years. Was a bit of a hurdle to get going initially, because it required a change to policy at the UNOS and federal level to allow the use of a HIV positive infected tissue to be put into a human. But these are being done now in 20 centers across the United States on a research-based protocol to see if this is possible, and another area where we can pull more kidneys for transplant for those who need them. We're not involved in this HOPE study at the moment. Moving on to hepatitis C, it's another area, and perhaps some light on the background of a kind of dark and sad story. We all know in the last 10 or 20 years, we've been going through an opioid epidemic and crisis. And this infographic highlights and shows you that there's a lot of young people who are dying due to opiate-related deaths. And at the same time, and related to this opioid crisis, there's been an increase in hepatitis C infection. So if you think about it from a transplanter's point of view, if you remove the hepatitis C factor, a lot of these donors would be excellent donors, otherwise young and fit, and their organs would be quite suitable for transplantation. And luckily, in the last few years, we've had coming online highly effective hepatitis C drug therapy, which can completely suppress and remove hepatitis C. And so coupled with this, more and more centers have been starting to use hepatitis C positive organ donors into a regular hepatitis C negative recipient. Years ago, we would only ever use a hepatitis C donor kidney and put it into a hepatitis C positive recipient. But here we can do this and use these organs, which are usually, as I mentioned, coming from very healthy donors. And this program is now growing for us, and we're doing about 25 to 30 per year. And actually so successful that we're changing our consent policy to be an opt-out policy. So of course, we want to make sure that the patients are pretty stable. We don't like to have co-infections yet with this group of patients with HIV or hepatitis B. And obviously, we need to ensure that they're going to be able to pay for these expensive drugs. We work very closely with our ID and hepatology colleagues and screen them thoroughly peri-transplant and post-transplant, looking for seroconversion and then treating them appropriately. And here's a list of some usual drugs that we use, with Mavorite listed in red because it has no GFR implications, which obviously in the setting of a kidney disease and transplantation you need to consider. Another thing that we can offer is ABO incompatibility transplant. Sometimes when patients come to our clinic seeking a transplant, they bring with them a potential living donor, but they might have a different blood group, and usually those blood groups cannot be transplanted from different blood groups unless you're the universal donor of O. And here the infographic just highlights in green the usual pathways of donor to recipient in terms of blood group. But there are a couple of patients who actually, when you test for their anti-A or anti-B isotiters, and if they're relatively low, we can, in some circumstances, move forward and transplant across the ABO incompatibility barrier. So to do this, their titer needs to be 128 or less, and we precondition the recipient for about a month pre-transplant and give them pheresis if required to get those antibodies down to a reasonable level. And then if you do come across a patient who's getting prepared for an ABO incompatible transplant, frequently our end-stage kidney disease patients are anemic and may require blood products. Always think twice about what blood type of blood product you're going to give to the patient. So another thing that we can offer is a paired kidney exchange. So as I mentioned, not infrequently, a patient will come wanting a kidney transplant and bring with them some potential donors to the clinic, but they might not be compatible due to ABO incompatibility or HLA incompatibility. But sometimes what we can do is look at the rest of our patients in our program, and there might be another pair in a similar situation. And if you can match those pairs according to the diagram shown here on the left-hand side, we can do this paired kidney exchange. And in that situation, when you bring your living donor, who unfortunately is not a match to you, you will still get a high quality living kidney that will last you about, on average, 20 years, as opposed to a deceased kidney of 10 years. There are some programs out there in the country that help organize and coordinate finding a second pair for this situation. And we're part of some of those programs across the United States. More rarely, on the right-hand side, and you've probably heard on the news, we can transplant across chains, as highlighted in the diagram on the right-hand side. This usually starts with an altruistic or good Samaritan donor who wants to offer their kidney for transplantation. And then you can put together a number of pairs and transplant them in the chain as shown. This obviously is a huge logistical task and usually requires a number of centers getting involved in a number of different parts of the country. So very hard to do, but 10 or 20 chains of this type have been done in the past. So moving on to the last piece of my talk, and an area that I think is really fascinating and actually has hit the limelight in the kidney and the transplant space in the last couple of years, and that's the question or the possibility of xenotransplantation. So the idea of xenotransplantation has been around a long time, but there's been huge hurdles that we've kind of known about for years, but haven't really been able to tackle. So the idea of xenotransplantation, to just give you the basics, is that, you know, put a non-human kidney into a human, and the types of animals that have been looked at is the pig mainly. But there are a lot of differences between pig tissue or kidney and humans, and that's kind of highlighted on the left-hand side of this slide. One which you may know is this glycoprotein called alpha-gal, which is found on cells of pig tissue, but not in human tissue. And so if a human was exposed to this, you get rapid and aggressive rejection. But there are other issues. So the way the innate immune system is controlled in the human is quite different to the pig. Similarly, thromboregulation is different, and there's some genes and proteins that are found in the human that you can't find in the pig. There's some self-recognition issues that are different. For example, recognizing self from an NK cell point of view. Another interesting aspect is if you took a pig kidney and put it into a human, that pig kidney would actually keep growing and growing and growing. So you need to think about that, and the growth hormone receptor axis is something that could be tackled to stop that. And then finally, you need to think about zoonoses. There are a lot of porcine retroviruses that, of course, if you introduced into the human, it would be an ethical issue, and you wouldn't really know how that would turn out if you consider it. So the right-hand side kind of gives you a full list of all of the different genes and proteins that you need to consider that are different between these two species. And actually, now with the onset of CRISPR technology and other advanced genomics, you've been able to manufacture a tissue that might be more suitable to xenotransplantation. And there is a company now that actually can make these pigs that's called the 10GE pig, or 10 gene-edited pig, where you knock in 6 human genes to counteract the issues that I've just described, and knock out 4 pig genes, including alpha-gal, or the enzyme that makes alpha-gal, to try and mitigate some of these challenges in xenotransplantation. So this is the type of pig that the UAB group has used. And actually in the last year, there's been 2 big publications done by 2 big centers who have done these transplants. So firstly, looking at the UAB group who published last year on their experience in xenotransplantation. Obviously, this was a huge ethical challenge as well as a huge medical challenge. And the model that they used to do this type of transplant is referred to as the Decedent model. So obviously, we want to try and consider transplanting into a human. So the Decedent model is basically when a patient is dying or in the ICU situation, patient and or family are consented to allow this transplant to occur on a brain dead donor who's still supported in an ICU research setting. So what the UAB group was in this setting, in this model, they removed the 2 native kidneys and put in 2 10GE pig kidneys into this patient, and then monitor some physiology on the left-hand side to see, for example, how much urine is made. And then on the right-hand side, at the end of the experiment, they took the pig kidneys and did some histology to see what kind of an alloimmune reaction or other types of damage might have occurred to the kidney to see if this is sustainable. And this was done over a 3-day period. The NYU group did something slightly different. Again, they used the Decedent model. They used a similar pig model where these human genes knocked in and pig genes knocked out. And they did 2 experiments in this paper, and it was published in New England last year. They put one pig kidney into the groin of each patient, and this was an externalized kidney so they could see what was going on perfusion. They monitored some physiology as shown in the middle, and again, some histology at the end of these 2-day experiments to see what the kidney looked like in terms of alloimmune damage. So these were hailed as successes and really interesting experiments, obviously extremely specialized with a lot of work required to carry them out. So to summarize my part of the talk, I just hope I highlighted that the prevalence of end-stage kidney disease in the US is massive. Kidney transplantation offers the best treatment for these patients, but there's a huge supply issue of kidneys, and we're not matching the number of patients that require them. And we need to think about more ways of increasing the supply of organ donors and getting more patients transplanted. I think we do very well at WashU and Barnes here. Our transplant program is large and our outcomes are very good. And perhaps the future is xenotransplantation, but just keep an eye on that space. And finally, I'd like to thank you for listening. And I'd like to thank my transplant nephrology colleagues and my transplant surgical colleagues for all of the good work that they do. Hand it over to Dr. Pan.
Thank you so much, Dr. Malone. It's a pleasure to speak with you all today. My name is Jason Pan. I'm a newly joined faculty, and we'll be talking about adult liver transplant today. Here's an outline of my talk. We'll cover the indications, contraindications, selection and allocation process, and then talk a little bit about some special populations that might be of interest to you all. So similarly, I have a timeline of the history of liver transplant as well. So, there are a lot of themes that can be established by looking at this timeline. There's a concept of bench to bedside. There are ethical principles that have to be clarified in order to achieve transplant. There are things that have to be established at a government and societal level to achieve transplant. And, even now there are significant developments in terms of how we allocate with things like the MELD score and the MELD sodium score. And the future of transplant in hepatology continues to shine brightly. There are new techniques such as normothermic perfusion that is being developed. There will be an update to the MELD score, the MELD 3.0, that should be coming out shortly, that further enhances allocation. So just to give you a bit of an overview of liver transplant centers, there's 147 liver transplant centers in the US. At any time, there's about 13,000 patients on the wait list for liver transplant, and only 9,000 are performed annually in adults. There's about 500 to 600 pediatric transplants done annually. And so there is there's clearly about a 4,000 person shortage of liver transplants. And in cirrhosis, there is no dialysis that can hold them over when you truly are ill. Your mortality for 90 days to a year is quite high. The most common type of liver transplant performed is a deceased donor, and only 6% are done with living donors, in contrast to kidney transplant. The 1-year survival after transplant is 93%. So there is a bit of a risk-benefit discussion that has to be had with patients. And the 5-year patient survival from liver transplant is excellent. It's 80%. At any time, about 10% of people on the wait list will pass away waiting. Some trends in the liver transplant world. So as you can see, the total number of liver transplant volume has been gradually increasing over the years, but it's not due to us using more living donors. It's truly because we're using more extended criteria organs. So similarly, we're using hepatitis C positive organs. Now that hepatitis C is positive, we're using hepatitis B core antibody positive organs as well. And we are all increasingly using donors who died by cardiac or circulatory death rather than brain death. And as a result, waitlist death has been gradually coming down a bit. And as our techniques and immunosuppression protocols have improved, 1-year survival has been gradually improving, as has 5-year survival. So the SRTR is a very helpful website for patients and physicians and providers to be using. It's a national registry that covers all liver transplant and all solid organ transplant by center, by region. It provides patients and providers information about how each center is doing. It's updated regularly, about, I think, every 6 months. I just pulled the data for volume for the liver transplant centers in Missouri. Barnes Jewish is the largest in the area. And kind of similar to Dr. Malone's talk, you know, the average MELD score at transplant is highly variable across the country. So in other parts of the country, the median MELD at transplant is 35. And if you think about what a liver patient with a MELD of 35 looks like, it's a pretty ill patient. It wouldn't be surprising for them to be in the ICU. But in St. Louis, because of our location, our median MELD at transplant is on the lower side of the national median. So to cover the approach to selection for liver transplant, you know, at every selection meeting, when we think about a patient, this is kind of the approach we think about them. First, you know, is there a strong indication that this patient truly needs to go through liver transplant in its process, considering the risks of the procedure? Are there any cardiopulmonary contraindications? Because when you think about the surgery and when you reperfuse this organ that's undergone ischemia reperfusion injury and the massive increase in preload when you reperfuse the organ, the heart and lungs need to be able to tolerate that. And I'll show you some cardiovascular data in a second. 3, are there any psychosocial barriers to compliance that will ensure that this graft goes to the best candidate, will make sure that they continue to do well? 4, is there significant frailty or malnutrition? Are there any surgical barriers to them undergoing liver transplant? So the 3 general categories for indications for transplant are, you know, you're a patient with liver disease, you have an elevated 7-day or 90-day mortality, you have a malignancy that can be treatable with liver transplant, or you have a metabolic disease that is treatable with liver transplant. So examples of people with an elevated 7-day mortality are patients with acute liver failure. So patients who don't have any underlying liver disease, who suffer a significant acute liver injury that causes their liver to fail, and they have no signs of spontaneous recovery. Or post-transplant patients who develop hepatic artery thrombosis or primary non-function of their graft after transplant. Patients with an elevated 90-day mortality are typically the decompensated cirrhotic patients, and this is evidenced by a MELD greater than 15. Malignancies that are transplantable include liver cancer, hilar cholangiocarcinoma, hepatoblastomas, and there are some rare liver malignancies that exist as well. And then metabolic diseases include primary hyperoxaluria, cystic fibrosis associated liver disease, some organic acidemias seen often in the pediatric population rather than the adult, and FAP. So the reason for transplant has been evolving over time. As hepatitis C became treatable, you know, hepatitis C went from being the #1 indication for liver transplant to like #3 and probably still going down from there. Meanwhile, alcohol use in this country has continued to increase. Alcohol use disorder has continued to increase. It was certainly not helped by the pandemic, and alcohol is currently the #1 reason. Fatty liver disease from non-alcoholic causes is on the rise as well. So this is highlighted in this table in a slightly different way. The magenta line here you see is alcohol liver disease. The blue-green line is for all, it's a combination of causes, including NAFLD, but not purely NAFLD. So you can clearly see that alcohol has been exponentially rising as the #1 cause of transplant. And you can see, on the other hand, hepatitis C has declined significantly. So when we evaluate a patient, the patient is seen by a variety of providers of various disciplines who all provide valuable input. Assessment of, as you may have seen, you know, a wide variety of assessments are done to ensure that the heart and lungs are strong enough to tolerate liver transplant, that infections, because patient will be on heavy immunosuppression, are not present, that they're already immunized appropriately, and that any possible prior exposure to any infections that could reactivate our screen for. Appropriate cancer screening should be done, as well as dental disease screening, to make sure we're selecting for the best candidates who have a good life expectancy, and cross-sectional imaging is obtained for surgical planning. And then, you know, it's very important in the liver world to because of the impact of alcohol and substance use on liver disease, that this is assessed appropriately. Social support is also assessed. The patient's finances, insurance status is also reviewed to ensure that they can continue to get the immunosuppression medications and continue to follow up with us after transplant. And then we review their understanding of the process. There's a whole education component. So to get into some of the absolute contraindications, patients who have significant cardiopulmonary disease, patients who have significant barriers to compliance, poorly controlled HIV with CD4 counts below 100 and active HIV infections that are uncontrolled are contraindications, as are patients with active malignancy, uncontrolled sepsis, and prohibitive anatomic abnormalities, hence the cross-sectional imaging. So in general, the general categories for cardiopulmonary contraindications include heart failure, severe pulmonary hypertension that's refractory to any treatment, severe untreated heart disease, and respiratory failure requiring significant mechanical ventilation. An EF less than 40% is an absolute contraindication. Moderate to severe right heart failure is a contraindication. The mean PA pressure over 35 has significant negative prognostic predictions for their survival from transplant, as is a PVR greater than 3 Woods units. And then if they have multi-vessel untreated coronary artery disease or irreversible severe valvular disease, these are all contraindications. So why is this topic so important? So the 30-day mortality after liver transplant, the number one cause is cardiovascular disease, accounting for 40% of deaths, particularly cardiac arrest in half of these cases. And so, if people are revascularized, their post-liver transplant survival is not impacted, but it's probably, this statistic probably has more to do with the cirrhotic cardiomyopathy that seems to underlie many patients with severe cirrhosis. Some relative contraindications include age over 70, BMI over 40, severe malnutrition and frailty, but these are kind of reviewed on a case-by-case basis. So, our patient has passed the selection process. So now how do they actually get allocated a liver transplant? So using the OPTN's policies, after a patient is approved by our center for liver transplant, they're assigned one of 4 categories. One, they could be assigned their calculated MELD sodium score. And we're thinking there's currently a proposed updated version of the MELD score that's under review that uses sex and albumin to further enhance the calculation. If their MELD score is low, they might qualify for a MELD exception, and we'll go over some of the conditions that earn a MELD exception to boost their MELD score. If they're really ill and they have a high 7-day mortality, they would be listed as adult status 1A, which is the highest priority in the allocation process. Or, if something is happening, they look particularly ill, there's an infection that's active, or something has occurred, they could be made temporarily inactive on the list. So a little bit about the MELD score, because it's something that we're always calculating on Epic. You can do .MELD and it generates their MELD score. It is good to know a little bit about what is this number coming from when it comes to transplant. So when OPTN calculates the patient's MELD score, they first use the original MELD formula that was developed at the Mayo Clinic. But there's certain things that are done. So if the lab values are less than 1, they're capped at 1 because it's a logarithmic calculation, so you don't want negative logs. And then the creatinine is capped at 4, or if the patient has a creatinine greater than 4, it's capped at 4. If they're on any dialysis, it's capped at 4. And then if the MELD is greater than 11, there was that update to the MELD score, the MELD sodium. And it's because low sodium predicts increased mortality and cirrhosis, particularly when people have renal dysfunction. So there's certain caps where a sodium less than 125 is capped at 125, and a sodium greater than 137 is capped at 137. But in general, low sodium will boost their score. And as a result, in the MELD listing on UNOS, scores are capped only between 60 and 40. So, when I hear that a MELD score is greater than 40, it doesn't have much bearing on their, increased opportunity for transplant, but certainly it has significant prognosis predictors. Some standard MELD exception conditions include hepatopulmonary syndrome, portopulmonary hypertension, liver cancer, hyalocholangiocarcinoma, and then some of these metabolic disorders. And OPTN's policy is constantly updated and available online, and they delineate the conditions for these MELD exception. So we talked a little bit about adult status 1A, and these are patients who are at very high risk of death. And so these are patients with acute liver failure, primary non-function within the first week of transplant, people who have hepatic artery thrombosis within 7 days of transplant and have essentially a non-working liver graft, patients who are anhepatic, or patients admitted with acute decompensated Wilson's disease, which essentially is another form of acute liver failure. So those are the assignments you could get. So then how does one actually get their transplant? So when a donor is identified, an algorithm is run to match them based on blood type, and then prioritization according to status. So first, any status 1A or 1B candidates are identified within 500 nautical miles of a donor hospital. And if no one qualifies, then they move down the allocation process according to the chart on the right. So then they look at, are there any patients with a MELD between 37 to 40 in the area, first at 150 nautical miles. If not, then they expand to 250. And then finally, they expand to 500 nautical miles. So in the liver world, where distance is important because we want to try to minimize the amount of cold ischemia time that the organ is awaiting to be transplanted. Finally, I'll just touch upon some special populations in the transplant world that might be of great interest to you all. So I'll first start with severe alcoholic hepatitis. So these are patients who have a MADRI score greater than 32. They have already failed a course of steroids with an elevated Lille score greater than 0.45. This graph is highly informative of this disease condition. So on the bottom curve are just matched controls who meet this criteria I described. You can see that their 6-month survival is only 23%. So if you are trying to assess a patient who has an alcohol use disorder and you don't have the time to monitor them for prolonged alcohol cessation, you don't have time for them to undergo alcohol counseling and alcohol use disorder, given how high this mortality is, how do you select who can undergo liver transplant? Because when you look at this data, if you carefully select these candidates, the survival is quite incredible. When they receive a liver transplant, their 6-month survival suddenly goes up to 77%. And at 24 months, the survival still remains at 72%. So in the US, there was a Dallas consensus that proposed some predictors of what is a candidate who has severe alcoholic hepatitis who might be at low risk of alcohol relapse. And so these are kind of the questions I ask when I get called from a transfer center. So first thing I want to know is the presentation. Is this a person who is having their first episode of alcohol-related hepatitis? It's not a recurrent episode. Is the patient alert and awake enough that we can interview them and understand their insight and get a sense of their candor about their alcohol use and their alcohol-related problems in the past? Psychosocially, are there any severe uncontrolled psychiatric comorbidities that would make them high risk for relapse? And then what is their social support system like? Are they living with at least 2 sober people who can kind of keep an eye out on them? And then past history can be very important as well. So a predictor of severe alcohol use disorder, patient at high risk of alcohol relapse would include multiple failed rehabilitation attempts, people who've had legal problems due to their alcohol, and people who have polysubstance use. And so often we argue that because we have very little time with these patients, we need to get them transplanted relatively soon. They can't be patients who've been repeatedly told to stop drinking, and they need to have demonstrated history of medical adherence to suggest they're a good candidate when they have severe alcohol-related hepatitis. Another very exciting area of liver transplant these days is hepatocellular carcinoma. So these are often patients who don't have a high MELD score, but they have disease that can be transplantable. And so, these criteria are basically the Malone criteria you may have heard of. So if a patient has a single HCC lesion between 2 to 5 centimeters, or they have 2 to 3 HCC lesions between 1 to 3 centimeters, there's no evidence of any extrahepatic disease or major vascular invasion. Their AFP is under 1,000, and their cancer does not spread beyond these criteria for 6 months. They can be transplanted. And you can see the 5-year survival is 77%. So essentially they're cured of liver cancer. So liver transplant still represents the best treatment for liver cancer at this time. And then kind of exciting data is also present for hilar cholangiocarcinoma these days. It's important to note that there's a high risk of seeding with these types of Klatskin tumors or hilar cholangios. So it's important to avoid transperitoneal biopsy, but brushings and spider bites would be a fine way to biopsy these. And so in transplant, you can achieve a 65% 5-year survival in transplanting hilar cholangiocarcinomas these days, but in a very highly selected population. So the transplant criteria would include that the tumor size is less than 3 centimeters, that there's no evidence of progression while they receive neoadjuvant chemoradiation therapy, and that there's no evidence of extrahepatic disease on an exploratory laparotomy to further stage them just prior to listing. In the study where they demonstrated a 5-year survival of 65%, 12% of patients dropped out in 3 months before transplant after they had completed their neoadjuvant therapy, half of which because they were found to have extrahepatic disease on surgical staging. So that step is quite important. And then some of you may be kind of curious, we're talking today kidney and liver transplant. What are some of the criteria for simultaneous liver kidney transplant? So there's 3 general categories defined by GFR and duration, as well as whether they're on dialysis, for us to determine if someone should get a simultaneous kidney liver transplant. And these are defined by UNOS. But say a liver patient currently does not qualify for simultaneous liver kidney, but their renal disease persists after transplant. There is a protocol, the safety net kidney protocol, where liver transplant patients can be prioritized if they continue to have significant renal impairment between 60 days and 1 year of their transplant. So my final thought is liver transplant is a life-saving procedure for carefully selected patients. And there's a window of opportunity for them to be transplanted where they have to be evaluated late enough that they have an indication for transplant, but also early enough before they've developed the severe comorbidities that would preclude transplant. Thank you so much.
Thank you so much for those terrific talks. We have some time for questions. Up in the back.
Yeah.
Can you repeat the question for the?
Sure. So the question was, we were talking about 5-year survivals for a variety of indications. The 5-year survival for cholangiocarcinoma was about 65% in optimal cases. So how do we kind of determine, what we should be transplanting, given that there are other transplant indications that have higher survival as high as 80%, I think, especially when there's a 4,000 person shortage at any time. And I think it partially, some of these special indications like cholangiocarcinoma are really quite rare. Like they don't occupy a very large percentage of the people who are transplanted. That protocol is extremely rigorous, and in the end, in the whole country, there might be maybe only like 50 people who are transplanted. So I don't think it's too much of a burden. Yeah, and these days there are also, I mentioned we were doing normothermic perfusion research studies, and there are a variety of ways to get to transplant without putting a strain on the transplant pool. So, at some centers, living donation is an excellent way to transplant some of these more risky indications.
Sure. So the question is, why the big difference in survival of a kidney that came from a deceased donor compared to a living donor? Well, I'll probably start at the other end. And the living donor, first of all, is an extremely healthy person. And it's a highly coordinated procedure. So they pass all these tests. They have excellent kidney function and literally no comorbidities. And the surgeries are done on the same day. So literally there's two ORs side by side. And so there's a very little ischemia time and no cold ischemia time. Whereas on the deceased waiting list, you have a huge variety of patients that are becoming donors, and many of them are in hospital for an illness themselves that is usually not a kidney illness, obviously, but they're sick, might be hypotensive, and then once they do become an organ, frequently the organ has to travel across the country. And with our new allocation system in kidney, there's a 250 nautical mile radius around the donor hospital. So there's occasions where the kidney might go from St. Louis to Chicago and they say no, and it goes down to Nashville and they say no, and then it goes up to St. Louis again. So for example, that puts a lot of time on the kidney and it's in a box of ice. So it just doesn't do as well.
Both comment on the health equity issues related to getting on the donor list and also donor availability and then outcomes of transplants in people of different ethnic and socioeconomic backgrounds?
So I'll take a step at that. So excellent question. And it is a huge issue. And I'm involved quite a lot at policy level and in our society, the American Society of Nephrology. We do a lot of canvassing on Capitol Hill to try and change policy and make it more equitable for kidney patients to get on the transplant list. There are certain things that disadvantage somebody who's from a lower socioeconomic bracket, if you like. If you have some money, you can travel to different parts of the country and get yourself worked up and be put on a transplant waiting list at multiple hospitals and fly to the one that gets you to the top of the list quicker. And strategies to try and make that more equitable have been looked at. For example, allowing more free transfer of data between centers so that a patient who might not be able to fly to San Francisco and to Chicago and to New York, their workup data can be shared across those centers and allow them get on the list in 3 different parts of the country without having to spend all the money to do so. So yeah, there are a lot of challenges. That's just one example, and definitely the kidney and transplant community are trying to mitigate those to make it more equitable.
Yeah, kind of to echo the kidney world, in the liver transplant world, there certainly are social disparities and health inequities that exist. It's an area of active research. One of the hepatologists, Lauren Nephew, has published quite a bit on this topic. And yeah, we do our best in terms of utilizing our social workers to try to reduce the barriers that prevent people from getting to liver transplant, as well as just making sure that this is a resource that is understood to be available to everyone.
So to repeat the question, is it possible to breed a herd of pigs that are free from porcine retroviruses? I, to think a little bit about that, but I'm thinking that yes, it possibly is. And I think a lot of these pigs are probably bred in a similar situation. These 10G pigs I mentioned, the 6 human kidney or human gene knock-in and 4 knockout, but they've also probably eradicated or bred out many of these porcine retroviruses as well to be allowed to do these experiments. But the details, I'm not so sure.
I think we'll have to stop there, but thank you both very much.